After completing the Module 15, you should be able to master the knowledge of the following: the prevalence of musculoskeletal disorders and related health challenges, the physical challenges associated with low levels of musculoskeletal fitness, as well as common testing methodologies to assess musculoskeletal fitness, and how physical activity affects bone, joint, muscle mass, and muscle function in relationship to musculoskeletal health. Close your eyes, and think about the answers for the below two questions. Can exercise improve the strength and quality of bone tissue? Why is muscle quantity and muscle quality important for good health? Although much of the scientific and popular attention on physical activity and health has focused on how exercise helps the cardiovascular and metabolic systems, we are learning that the benefits to the musculoskeletal system are just as important. Scientific evidence clearly supports the importance of maintaining physical activity as we age to optimize physiological capacity, minimize physiological limitations, maintain functional and rollability, and reduce the risks of falls. In this module, we will answer the two questions on this slide. The prevalence of common musculoskeletal challenges such as osteoporosis, bone health, osteoarthritis, joint health, and low levels of the quantity and quality of muscle are high in the U.S. population. Osteoporosis, such as low bone mass and structural deterioration of bone tissue, is estimated to be a public health threat to 44 million Americans, or 55% of those over 50 years of age. Clearly established diagnostic criteria for osteoporosis exist. People with a bone mineral density below the normal range have the disease. Women are much more likely than men to have osteoporosis. Of the 10 million people estimated to have osteoporosis in the US in 2010, approximately 80% were women and 20% were men. Then, why is osteoporosis a problem? Most important, osteoporosis and low bone mineral density contribute to increased bone fracture risk, including fractures of the hip, vertebral column, and wrist. The risk of falling is increasingly a problem as we age, and low bone mineral density can accelerate the risk of fractures that are either spontaneous or secondary to a fall. Due primarily to the aging of the U.S. population, the incidence of bone fractures resulting from osteoporosis and low bone mineral density is expected to increase by 1 million more cases by 2025, which will contribute to lower quality of life, higher disease management costs, and increased mortality for those effects. The economic cost of osteoporosis and low bone mineral density associated with osteoporosis-related fractures was $19 billion in 2005. And has been predicted to affect 3 million people at a cost of $25 billion by 2025. There are several types of arthritis. Osteoarthritis OA is the most common form of joint disease and is associated with joint pain and dysfunction along with an irreversible loss of articular cartilage. Osteoporosis is associated with bone health, in which a person has low bone mass and structural deterioration of bone tissue. Osteoarthritis is associated with joint health, in which a person has joint pain and dysfunction along with irreversible loss of articular cartilage. Osteoarthritis is often thought of as a mechanical joint disease affecting primarily the weight-bearing joints, knees, and hips. Clinically, osteoarthritis symptoms include joint pain, swelling, stiffness, and weakness. The development of osteoarthritis is associated with increased disability and lifestyle challenges. Approximately 27 million U.S. adults are affected by this most common form of arthritis, and it is also the fifth leading cause of disability. To put this into perspective, California is the only state in the U.S. with more than 27 million people. Women are affected with osteoarthritis more than men are, especially related to the knee. By the year 2030, it has been predicted that 67 million people, or 25% of the U.S. population, will suffer from osteoarthritis. Common risk factors for most musculoskeletal disorders are physical inactivity, overweight, sex, heredity, and age. Then, what are common risk factors for musculoskeletal health challenges? The modifiable risk factors include physical inactivity and tobacco use, while the non-modifiable risk factors include age, sex, and heredity genetics. For example, with osteoporosis, people who are physically inactive are less likely to have optimal bone mineral density than their more active players. Smokers reduce their ability to absorb calcium, which is important for good bone health, and smoking also tends to interfere with estrogen and bone protection. Advancing age is associated with increased osteoporosis risk because of physiological changes associated with aging and bone loss. Women are at a higher risk for osteoporosis than men at an earlier age. A family history of osteoporosis can increase the risk for developing the condition. As we can tell, many, but not all, musculoskeletal health challenges are associated with sedentary lifestyles or low levels of physical activity. In terms of kinesiology and musculoskeletal health, the physiological, biomechanical, and psychological benefits of participating in physical activity and exercise on musculoskeletal health are numerous. Then, what 5 long-term adaptations to physical activity and exercise are associated with increased musculoskeletal health? Answers may vary but include the following. For physiological benefits, physical activity participation may lead to increased muscular strength, increased muscular endurance, increased VO2 max, increased muscle force and power, increased muscle fiber size, improved neural recruitment, increases in anaerobic enzymes, increased anaerobic energy stores, improved hormone-mediated bone remodeling, improved connective tissue function, no change or increase in BMD, maintenance of or increase in lean muscle mass, maintenance or loss of weight. As for biomechanical benefits, regular physical activity participation may lead to improved economy, improved balance, improved mobility, increased motor skill function, improved proprioception that helps in movement and balance. For the psychological benefits, regular physical activity participation may result in increased self-esteem and self-confidence, improved self-efficacy, and decreased depression and anxiety. Common musculoskeletal tests can be used to determine levels of strength, muscular endurance, power, balance, gait, and mobility. What are 6 common tests of musculoskeletal fitness or function? To assess strength, we can use 1 repetition maximum, 5 repetition maximum, 10 repetition maximum, hand grip dynamometry, isokinetic dynamometry. To test muscular endurance, we can measure number of lifts per 70% of 1 RM, push UPS, pull UPS, sit UPS, sit to stand tests, sport-specific tests. The tests for power include Wingate anaerobic power test, standing long jump, vertical jump. Tests for balance include one-leg stand, gait speed, vert balance scale. Gait tests are get up and go, curve course walk. Mobility tests include goniometer test. Bone strength can be assessed by DEXA, ultrasound. We are concerned with the below question: how much physical activity is needed for good musculoskeletal health? You may think about this question for 1 minute before you move to the next slide. To reach the optimal benefits for musculoskeletal health as a result of physical activity participation, youth should engage in muscle strengthening activities that include the major muscle groups at least 3 days per week, and adults should participate at least 2 days per week. Then, What are the dose-response relationships between physical activity or exercise and the various indicators of musculoskeletal health? What are the dose-response relationships between physical activity or exercise and the various indicators of musculoskeletal health? Answers may vary depending on the specific musculoskeletal problem but include the following. The effective dose of physical activity and exercise for musculoskeletal health varies depending on the desired outcome: bone, joint, or muscle health. For bone health and depending on the study, 4 hours of walking per week, 2 to 4 hours of moderate or vigorous intensity physical activity each week, and/or 1 hour of physical activity are associated with a 36 to 41% reduction in the risk of hip fracture. The suggested dose of physical activity and exercise for adults with arthritis to reduce pain and disability and increase function is 130 to 150 minutes per week of moderate intensity. Low-impact activity, experts suggest 30 to 60 minutes per session, 3 to 5 days per week. No specific time has been recommended for resistance work, but people should perform to the point at which performing another repetition without help would be difficult. Resistance training involving one set of 8 to 12 repetitions using several muscle groups has increased strength, although performing 2 or 3 sets with the appropriate amount of rest between sets may be more effective. Muscular strength and endurance changes occur progressively over time, and increases in the amount of weight, frequency, or both can result in greater changes. This table contains specific examples of muscle strengthening and bone strengthening activities for children and adolescents, as well as for adults and older adults. As known, children and adolescents do not need to engage in formal resistance training to acquire musculoskeletal benefits. Adults and older adults should engage in muscle strengthening activities involving all major muscle groups at moderately to vigorously intense levels at least twice per week to see improvements in muscular strength and endurance.